Okay, Chapter 19, Reproductive and Genetic Disorders. So we're going to cover that tomorrow in class. Just a little bit about that. Disclosure statement. I don't own the material under fair use. I'm providing lecture content for only my nursing students using this material, and all content within is for educational purposes of nursing students and does not provide medical advice. So some of the things that we're going to do in this chapter is identify the anatomy of male and female. You got to know that. You're going to need to know that anyway for med surg and everything else. So you might as well have those terms in your memory. Discussing pediatric reproductive health concerns, the most common ones that you'll see. Discuss an approach towards gender neutral care, sensitivity towards transgender youth, and describing signs, symptoms, and interventions for commonly sexually transmitted infections. That should be an overview from maternity as well, because you talk a lot about that with maternal patients as well. So that shouldn't be too bad. Explain human genome and its function. Again, that's coming from anatomy and physiology. If you didn't understand it then, you probably should understand it, because a lot of our dominant, recessive, and X-linked disorders come from that. So in understanding how the beginning of life occurs, you can better understand how the dysfunctions of that occur. So describing errors in reproduction, including mitosis, meiosis, and their contribution to genetic disorders. Explaining the difference and similarities among autosomal dominant, recessive, and X-linked disorders. So let's get started with that. If you are following along in your book, let me get to my second screen here. You can see on page 453 that there's female anatomy and physiology, and it goes through it really quick. So you probably need to know more on here regarding the hymen, especially if it's ruptured early, that may be an indication of abuse. Again, we are looking for anything abnormal in that area on a child, um, because that could be signs of abuse. We're not sure, but it at least raises our awareness. So if you look at the picture, make sure that you understand the difference between cervix, cervical os, isthmus, the ovary, the ovarian ligaments, the fundus, the fallopian tube, and the broad ligament. The broad ligament can cause a lot of pain, especially during childbirth, especially during ovulation. So take a little time and understand that really well. A fallopian tube, again, you will see this even in med surg. What they will say is a patient has missed their period, they are cramping and have abdominal pain. They will allude to the fact that it's radiating to the right shoulder. This is talking about a fallopian tube pregnancy. So know about that. A pregnancy that starts in the fallopian tube instead of in the fundus of the uterus is going to cause extreme pain, especially if it ruptures. When it ruptures, that's when you get that right shoulder pain. Why does that even occur? Well, blood that's in the perineum tends to hit the phrenic nerve, and the phrenic nerve shoots pain up to the right shoulder. So if there's a question about right shoulder pain, it's probably referring, as long as it's not in the context of a laparoscopic surgery, it's probably referring to a fallopian pregnancy, a tubal pregnancy. So that patient would be at high risk for blood loss. You would want to start your IV fluid quickly, replace blood products, and get her to the OR quick. So you'll hear more about that in maternity as well. So thinking about puberty changes in girls, you remember I've said a million times, you got to know the Tanner stages. Tanner stages, Tanner stages. Also see chapter 10 for this. Andrometry occurs when the adrenal gland starts to produce sex hormones. These outward changes are characterized by the stages of puberty. You need to know the Tanner stages. Racial and ethnic differences exist, onset in black girls slightly earlier than white girls. So again, they may be able to be pregnant earlier. So the stages in females, pubarchy is the appearance of pubic hair, thelarchy is the appearance of breast tissue, and then menarche is the beginning of the first menstruational cycle. So again, hair first, breast tissue next, then the start of a period. Precocious puberty is anything less than 8 years old, or considered delayed if it's over 16. So just consider that there are some genetic and environmental influences, including stress, that makes children have their period early or later. Some common pediatric problems of the female genital tract. Again, hold on, I gotta keep up with my PowerPoint. Some of the common issues with kids you will see. So, genital and urinary complaints are common in pediatrics. So, again, it could be redness, itching, discharge, bleeding, painful urination, or vaginal burning. We're always in the thought process of, is it a UTI? Is it something else going on? Are they toilet trained? Remember your UTI signs and symptoms, right? Even for an older adult, this is going to come back to bite you all the way along in the NCLEX because it could be any age group that's having a UTI. You need to know what a UTI looks like and sounds like. Okay. So, that UTI in kids, we talk a lot about cotton underwear, wipe front to back. We talk about all that quite a bit in maternity, in peds, in med surg, because UTIs are one of the most common infections that occur. And in pregnancy, it can lead to preterm labor. So there's usually some kind of infection going on when we're in preterm labor. So think about someone who is taking baths or showers, the degree of sexual maturity. If somebody keeps having UTIs and they're 9, we think about that because it could be sexual abuse as well. Um, Complaints resulting from infection, congenital anomalies, trauma. Is there something wrong with the area down there? Are they too close together? Is that what's causing them to have UTIs so much? A child should not have that many UTIs if they are doing the right things, which include making sure they're not constipated. Why does that happen? Look in your book on page 455. The anus and the vagina are so close together, they become even closer during pregnancy. So UTIs are specifically a pregnancy related thing. But look at inside in the rectum, how close that is to the vagina and the cervix. So if you're having a lot of abdominal pain, it could be constipation. That's your issue. So sometimes that's a test question, and they're trying to get you on what could cause urinary tract infections. Well, if the rectum is full of stool that's hard and dried out, it's going to put pressure on the vagina. That's going to put pressure on the bladder. That area is not very big inside. You could have a lot of issues with constipation as a child. So we want to make sure that they're on a bowel regimen and make sure that that's not happening. Think about if we were to see anal warts in a 9, 10-year-old. There's no reason there should be anal warts down there, right? So indications of abuse in this area, that's what we're really looking for. Also, infection control, so making sure they're wiping front to back, all that good stuff. So, straddle injury, when we talk about straddle injury, just think about it as saddle injury. So, if I was on a saddle and I came down quickly on it, like a bike, like monkey bars, like a horse saddle, it could have issues. So it's a fall over a blunt object in which tissues are compressed between the bone and the blunt object. Common in school age, common on the monkey bars, common on a bike. What happens is you get a hematoma in that area. Does it really need any special treatment? It will go away, right? But if it's big enough, including up to a size of a grapefruit, it may cause some obstruction and we're going to have trouble. We might have to do surgery and put in a suprapubic catheter while that area heals. If it's just small, it's ice packs, pressure, no big deal. Bed rest, ice, then warm tub baths and sits like tub cycling. So when we talk about sitz baths for an epidural, an episiotomy in a woman having childbirth, if we make a cut between the two holes to allow the baby's head to come out, we treat it the same way. So lots of warm tub baths, some sitz bath soaking, and also witch hazel to help healing. So lacerations and skin tears in this area, they shouldn't be occurring. There might be these things occurring with trauma, penetrating trauma, foreign bodies. Again, this is a problem because it's sounding like abuse. So we'd always evaluate for possible sexual childhood abuse. Areas and type of injury and the placement of the bruising really need to be seen by an abuse expert, and that's generally going to be your SANE nurses, SANE. So they are specific nurses who have been further trained in sexual assault nurse examination. So they are special people that live or are being housed in the ER, available at any moment in time that you talk to them about a child coming in and we need to do a forensic examination. It's forensic because it's going to be used in court, right? So thinking about that as well in this chapter, if you think that there's a rape or anything, the biggest thing on the test is not to allow that person to shower. You want to call that patient back first because in the moment they're going to think, let me get clean before I go to the ER. They're actually getting rid of our evidence. So you need to be very careful with that on the test question. Again, vulvovaginitis is an inflammation of the vulva and the vaginal area. Again, make sure you're aware of itching, soreness, redness, thin vaginal discharge, painful urination. So think about this just like your UTI, the tight nylon undergarments. We don't want nylon. We want cotton underwear. Bubble baths, perfume bath products, that can cause an infection. So really we don't want the bubble bath as much as possible. Think about a girl who's sitting in the bathtub for hours on end. Is the bathtub even clean? We don't know, right? So for some people, that's not going to be your best option. A shower is your best option, especially in hygiene areas. Before their period, this is more susceptible because the tissue actually lacks estrogen at that time. It's thinner and more susceptible to irritants. That could be tight clothing, like leotards, jeans, blue jeans. So think about some people like this might be dancers that are in a leotard for hours on end. Leotard should have a cotton crotch. Bubble bath, shampoos, deodorants, soaps, all these things, poor hygiene, obesity with more folds increases more trouble. So those are the people who are going to be most at risk for that. It also might indicate the presence of a vaginal foreign body. So 25 to 75% might present with odor or discharge. A vaginal foreign body might be something that was left in there, regardless how that got in there. So teaching would include teaching hygiene front to back. Consider what moist wipes rather than dry paper to wipe. Airflow, cotton underwear. Don't have tight clothing. Avoid sleeper pajamas. Typically in sleeper pajamas, you're not wearing underwear underneath. so it tends to have negative airflow. A warm bath for 10 to 15 minutes in clear water using gentle soap and rinsed just before getting out of the tub. Pat dry or use a hair dryer distant to the cool skin on a cool or low setting. So making sure that that's dry down there. You don't want it wet. Anytime there's a wet, moist environment, it's ripe for infection. So some other causes that we would look at, pinworm, vulvular ulcers, and imperformate hymen. So let's go through some of those as well. Some of those might be tiny worms, fecal oral route, that's pinworm. What do you think would be on the test question for that? It's generally that the females are in the tract, they're not shed in the stool, and they come out to lay eggs in warm perineal areas at night. So a great question for this is someone with pajamas on. Do you want a two-piece pajama or a one-piece pajama? Okay, think about that. If I have a two-piece pajama, they can get in and itch. I'm going to look under their nails for these pinworms in the morning. The other thing that you can do is the tape test, which is the sticky side of the tape to the butt area, and then you pull it off in the morning and see if you see those little worms or eggs in that area. So if they are talking pinworm, that's not ringworm, make sure you know the difference. And it's generally that there's perianal vulvar itching, especially during the night. So they might wake up with scratches. So you want to avoid that at all costs. That's why you want a one-piece pajama so that they can't get in there and itch during the night. Medications as prescribed. Also, just understanding that anytime you have contact with feces, you would want to wash your hands and use the bathroom and wash your hands very well. So this is seen in kids both ages, both sex equally. But it's a thought process to look at when you have a girl with multiple UTIs and stuff. It could be from that. The vulvar ulcers, these are seen in 10 to 15-year-olds, and they're more painful ulcers with a purulent base and raised edges. So, non-sexually transmitted. It's usually from a viral infection like influenza A, cytomegalovirus, CMV, but we should also test for herpes just in case. A history infection, a history of sexual assault, STIs, things like that, you still want to treat that as well and look for that. It might require a Foley catheter to let the area heal. Pain management. An imperformate hymen, think about this. If you don't have a rectum, you may not have this either. So that's the thought of imperformate means no hole. So there's no hole that could be seen at birth with a white or mucus material detained behind the area, but it will reabsorb if you miss it. It's present with a bluish bulge in teens and reports of not having their period. It's associated with chronic pain in the abdomen or the back with retained blood within the vagina. Because they don't have a hole, the blood can't come out. So surgical repair and reassuring a teen girl about body images. And again, pain management. So some of the most common adolescent vaginal complaints would be bacterial vaginosis. Again, you will hear about this in maternity because we have a lot of patients with this. This is not a big deal to worry about. It's easily treated. It's not an STD. So this is a vaginal discharge and bleeding. Anytime you have vaginal discharge or bleeding, you want to take a careful history, including all of the material like contraceptive use, what time is their normal period, how many days, the first cycle, and looking at your Tanner stages. So bacterial vaginosis is the most common vaginal discharge. Women of childbearing age and post-menopausal, post starting their period in adolescence. does not have to have anything to do with sexual contact of any kind. So it's a inflammation of the vagina. That's it. So how would I know? They will say a fishy smell, thin white grayish discharge. That's bacterial vaginosis. That's not something to call back first if you're triaging a patient. Okay. It's highly common, highly prevalent, especially in women who have sex with women. It is not from one organism, but it has more to do with the complex change in vaginal organisms and increase in other organisms. So 1/3 of cases resolve spontaneously without any treatment. You might consider treatment in partners of women having sex with women, but for the most part, it is somewhat associated with HIV and preterm labor, obviously. So we do have them come in and double check, is it just that? Because it could be other things as well. Abnormal uterine bleeding, think about shedding of the lining. You need to know the vaginal cycle, right? So if you look at this menstrual cycle uh, in your book on 457, there's a menstrual cycle. It's often irregular for the first months up to 3 years. Okay? So if you have a test question about a 14-year-old complaining about not missed periods and stuff, that's still expected. But a 21-year-old, when she started her period at 13, should be a little more regular by now. Remember your Negle's rule. When you do Negle's rule, you're thinking about pregnancy plus 7 days, right? So your first day of your last menstrual cycle plus 7 days. Then you are actually able to get pregnant. Okay? So it's not while you're having your period that you get pregnant. The problem is the plus 7 days. That's when you're going to get pregnant. That's the proliferative stage. So you need to understand that for OB, but you will also need to understand that for teenagers as well, so that you can talk them through how their cycle usually lasts. So one menstrual cycle usually lasts 2 to 7 days. So that's the problem when we say plus 7. If their normal period is 2 days, 7, they could already be pregnant. Okay. So this kind of goes in cycles of 21 to 45 days. And then eventually it'll get closer and closer. It'll be like every 21 days religiously. In the beginning, it's not uncommon for them to lose about 30 cc's. The upper limit of that normal is 80. So if I have someone losing 80 cc's of blood every month, they might get a little anemic. So think about that. That's usually why they're coming in, because, oh my gosh, this thing lasts for 10 days and it doesn't go away. Those are the common things that you're going to hear. So abnormal uterine bleeding is abnormal periods, frequent gynecological complaint in post-pubertal women. The menses will be irregular, especially in the first few years. An irregular cycle means the number of days to months between periods in the beginning. Once they're in adolescent stage, it should be much better. In the beginning, there'll be an anovulatory cycle, like a fake period, where they go through the cycle, but there's actually no egg being released. That's seen most commonly for the first 12 to 18 months after the start of their period. Then we go ahead and go into other questions that they might have for us, like hormonal contraceptives, stress, bleeding disorders, and endocrine disorders. So if someone's still having trouble with no period, no period, no period, we'll probably go ahead and do a thyroid panel and things like that as well. So amenorrhea, abnormal, so abscess of, so they don't have a normal menstrual period. Primary is the period has never presented itself. That's an endocrine evaluation. If there's nothing by 16 years, they need to be seen. We need a full, detailed physical history and reproductive family history. Secondary is when you have a period lapse of 3 cycles or 6 months when people who previously had menses. So this is secondary. It's most often common to pregnancy. So if you're pregnant, you're not going to have your period. So work up first by excluding pregnancy through a urine test or a blood pregnancy test. Then we can talk to the patient about what's going on. More times than not, when they don't have a period, it's because they missed their period because they're pregnant. So we just want to double check that is not the problem. Keeping track of your period, when it starts, when it ends, and then talking about hormonal therapy doesn't treat or prevent STIs. That's kind of a misnomer with teenagers that I'm on the pill, I'm good. Not really. So you're going to have questions about that. Menageria is characterized by the menstrual flow of excessive duration, greater than 7 days, heavy volume, greater than 80 cc's a cycle. Think about this. This is going to lead to blood loss and significant anemia. So these people are going to have to be checked quite frequently. And this could be from a couple different things. So if you think about it, it could be the indication of PCOS, so the polycystic ovarian syndrome. That's common, but we're going to have to look it up. We're going to have to check if we're having polycystic ovarian disease. Periods that last more than 7 days need to change pads more than 1 to 2 hours. So right there, you remember that from OB. If there's more than a pad an hour of blood, it's a problem. Get in here. You're hemorrhaging, right? So this carries over from OB a lot. Think about if you're losing that much blood, you're going to have orthostatic blood pressure, elevated heart rate, pallor, you're bleeding, right? So we also want to look up von Willebrand's as well, because that could be the most common inherited cause of excessive bleeding is a decreased function of the factor von Willebrand. So that's important for clotting and the platelets. Look at the discharge, okay? And then again, if you're not on an iron supplement, talk about foods that are rich in iron. So increasing their iron-rich foods during their period will help. Some people just need to take some iron every once in a while to make sure that they're okay. Think about that. What would this question look like? What do you eat with iron to make it happen? How do we make that iron more available to us? Orange juice. Acid rain on a tin roof, right? How do I break down a tin roof? I leave it uncovered in the elements, and acid rain helps break down and rust my roof. Same thing. If you want to break down iron tablets, add orange juice. Don't add milk. Why not milk? Calcium. Calcium binds to iron. Iron binds to calcium. I don't want to take pills that will absorb the iron at the same time. This is why we give Synthroid a half hour before breakfast. Synthroid, thyroid replacement, is very sensitive to protein, calcium, iron, things like that. So if you're taking your Synthroid with your iron pill, you're basically getting half of your Synthroid. Okay? So that's why your levels are never getting up. All right. So then we're going to break into the male anatomy. Again, males can also have problems, and that's why they would go to see their provider, especially a urologist. Okay, so obviously the penis, the scrotum, foreskin, testes, testicles, sperm, semen, spermatic cord, these are all going to be involved in emergencies of that area. Know that. Know your Tanner scale for boys. You know that. You know they're going to ask that. Okay? So, on page 458 in your book, just make sure that you know all of those things, what they're called, what their purpose is. You can see that the difference in the distance from the urethra to the anus in a guy is much larger. So you're not going to have very many UTIs on a boy. Think about that when you're a baby in a diaper. It is true that you are higher at risk. Okay? You're higher at risk because you're not able to get out of that wet diaper. So changing diapers frequently, using your Desitin and other waterproof creams, barrier creams, will help you with UTIs in both male and female, but also making sure that the skin doesn't break down. All right, so this epididymis, right? You need to know about that. That's the coiled tube on the back side of each testicle, which is transporting the sperm cells until they're produced in the testes and brings the sperm to maturity so that it's capable of fertilization. So you have two of those because you have two testes. Know how to do a testicular self-exam. Everybody focuses on the girl and the breast self-exam. No one sees the breast self-exam as a problem. What they'll do is change the question to be a male during peds. Okay, so know that how you do an exam and how you would do that is important to be able to teach. So instead of every period, like we do after our period for the female breast exam, think about having one time a month, like their birth date on their month. Okay, so if I was born January 27th, I would do it February 27th, March 27th, April 27th, to keep it consistent, because guys don't have periods like girls do, to be able to remind them to do that monthly self-exam. So some puberty, again, some things that we've already talked about, circumcision versus uncircumcised. Again, largely it's going to be a cultural or religious issue. It's usually done in infancy. Sometimes they'll wait a little bit to do it, only because there's issues with the penis, and we'll talk about that. So stages of puberty in males, again, endarchy is beginning to produce androgens. It's the onset of puberty. Pubarchy is the pubic hair appearance. And then gonarchy is when you actually have pituitary hormones coming out of your pituitary gland, follicle stimulating hormone, and luteinizing hormone. Okay. So circumcision is in your book in 459. Know the differences between Gomco and Plastibell. Again, the one on the top is Gomco. Less care, less work, more bleeding risk. Okay. The one on the bottom is Plastibell, where this plastic bell is left behind, so there is no care for mom. The only big thing to remember about circumcision is bleeding, and you saw that on the test. Bleeding is the big issue. Infection is a big issue, so knowing how to change diapers regularly, keep them dry, keep them happy. We know that we use the sucrose, the sweeties, for pain relief. You know that as well. So we're going to keep that in mind. What else? Primarily reduction in the risk of penile cancer, lower risk for females partners to develop cervical cancer, reduction in penile inflammation, and retractile disorders and easier hygiene is the reasons why people do circumcision. Mostly, like I said, it's a lot of religious or cultural preference. So provide your pain management, your sweeties, wash them with soap and water. Dressing might not be necessary. If it is, it's the Gomco one, and it's a petroleum impregnated gauze that we use. Alert the physician to any excessive bleeding, and you're looking for any oozing, swelling, drainage, not being able to pee, and just provide pain relief as needed. The uncircumcised penis is this next word that we're looking at right here. So phimosis is the inability to retract the foreskin. Not all infants have a fully retractable foreskin, so it may have to be forcefully retracted. That's a problem. Okay. So by seventh grade, only 1% of uncircumcised boys cannot retract the foreskin. So we're going to go ahead and tell the caregiver to leave the foreskin alone. Don't force retraction. As the foreskin naturally begins to retract, cleaning and then drying underneath can be performed. The foreskin should always be pulled down back to its normal position after drying. So remember this when you're doing your boys' Foley catheters. Put things back where you found them. All right. So typically we just provide them topical corticosteroids in 4 to 8 week courses and teach them how to do gentle stretch exercises to be able to do that. If there's a pathological issue, it's typically irritation or bleeding, painful urination, painful erection, and chronic urinary retention. So inability for the foreskin to retract. It's an emergency, medical emergency to provide help because you're going to have a vascular injury to the glands. So again, similar to taking your Viagra, you don't want an erection that lasts more than 3 hours. Steroid might be used if circumcision is not desired. Return the foreskin to its normal location. Okay. Zipper injuries. So, zipper entrapment is one of the most common genital injuries. Entrapment of the foreskin or the skin, localized edema and pain. Skin loss and necrosis is rare, so most often recommend cutting the zipper's median bar with wire cutters, bone cutters, or a small hacksaw. Sedation and pain control, and the only treatment is to release the zipper. So teach a child to carefully zip the pants once the underwear has been pulled up. Do not force zip the zipper, and provide help zippering. Okay. So development of the testes is next, and thinking about that, we did talk about this just a little bit in the Ballard assessment. So by age 12 weeks, the testes start to migrate down through the abdominal wall and reside in the scrotum. 10 weeks of gestational age and outpouching happens. And between the 7th and 9th month of gestation is when the testes actually go down into the scrotum. Once the process is complete, spontaneously, they should be down by age 2. Again, if the testes are not descended at birth, we don't care about it. We're just going to tell them to watch and make sure they make an appointment with the urologist. At 6 months, we might consider starting to talk about surgery and pulling one of those down, or both. So many males are born with incomplete descended testes, and the process might be completed after birth, especially in your preterm babies. Cryptorchidism is the undescended testes. So know that word. That's when it fails to come into the testes. It may be in the inguinal canal or even higher up in the groin. So they will be palpated on exam upon delivery. We refer to urology, like I said, and if by age 2 it's not down, then we start talking about potentially having to have surgery. Think about this. They go up and down based on the temperature. So think about loose clothing, ultrasound might be needed, but more times than not, they might just be too hot. So that's the underwear versus boxer theory, right? Think about kids having their computers on their lap. It's constantly warm in a baby boy, right? So you just want to be careful with those kind of things because that can lead to problems later on with not being able to have a baby. Okay, scrotal swelling. So that's wrong on this PowerPoint. It's supposed to be swelling, not sweating. And that's scrotal swelling. Most of these are painless. You divide them into painless or painful. Okay. So a painless collection of fluid is a hydrocele. Just think about that when you see that word. Hydro, water, cell, a collection of fluid. Okay. Fluid moves through um, that area to surround the testes. It's very common in newborns to have a very swollen collection of fluid, especially in breech babies. If you think about it, breech babies have been sitting down there on them for a long time. So a breech baby, absolutely no problem. What we usually do is transilluminate them, so put a pen light behind them, and if they transilluminate, we know that it's fluid and not blood. Usually it's in conjunction with an infection or trauma in older children. Most of the time it's going to resolve before 1 year of age and refer if at 1 year it's not gone away. We just refer them. Varioscocele. See, berry looks like blood, looks like something worse, right? So a painless collection of dilated and tortuous veins. So this is a blood issue. This is could be asymptomatic or present with a dull ache, and it's usually a tactile. It would look like a bag of worms or feel like a bag of worms, and might actually become fuller when bearing down or doing the Valsalva maneuver. Valsalva maneuver, push down like you gotta poop. It makes them actually bigger. Think about blood being trapped. So most associated with infertility, and it's observable into the teenage years. Not going to do very much with it unless it's having issues. So then your testicular torsion, that's what you want to be worried about. If it's painful, that's when you worry. So abrupt, severe, constant pain in the scrotum, lower abdomen, or groin, 90% has nausea and vomiting included with it. It's from 12 to 18, and it's scrotal edema, tender, swollen, slightly elevated. Intermittent torsion would be intermittent pain and then go away. So the only thing that we can do is go ahead and it's a surgical emergency. So this guy is the one you want to call back first in the ER or in the doctor's office because long-term viability of the testes relies on the time to derotate it. So we can also have a little bit of this with torsion of the appendix testes, which is the small remnant of the upper pole of the testes. So pain management, possible surgery, and diagnostic testing if needed. The inflammation of the epidermis is epididymitis, so infection of that area. So the testes is in more normal vertical lie, and the scrotum might be red or edematous. Chlamydia is the most common cause of this. So again, we do STD testing, STI testing, associated with structural anomalies of the urinary tract. So anytime you're having trouble, we're going to do full testing, make sure it's not a UTI, make sure there's no infection in that area. Orchitis, inflammation, infection of the testes, scrotal swelling, pain, tenderness. Again, bed rest, ice packs, NSAIDs, support. Primary inguinal hernia, a hernia with protrusion. So you need to know your hernias. They love to ask these, okay? Because we don't have really good abdominal muscles when we're born, inguinal hernia is pretty common. 3 to 4 times more common in males than females, bilaterally in about 10%. So inguinal hernia repair, if we see that they have this huge belly button, like poppin' fresh doughboy, literally you ask yourself, is it reducible? If it's reducible, leave it alone, right? If it goes back in, leave it alone. But if the problem is strangulation, that's what you don't want. So strangulation can occur within 2 hours of incarceration. So they might have a painless intermittent mass that reduces and then comes back. If it's reducing, we're okay. It's when it stays out that's a problem. So if you look on your book in page 462, you'll see the different places that you could have a hernia. The biggest one that we see, especially in the NICU, is umbilical. So we don't really see a lot of these. We see umbilical more, so you end up with little poppin' fresh doughboy. And as long as it's reducible, you're okay. So think about what you would do after surgery. Brace it with a pillow. You want to prevent dehiscence of the wound. You don't want the wound to open back up. So use a pillow or a blanket to cough, deep breathe. Watch for bleeding. No heavy lifting after repair, so they will not be able to heavy lift and go back to work or school. They will not be in gym class, those kind of things. STIs, there is a good cdc.gov chart in the book, and you can go ahead and look that up on your own. That's important to know, and you probably have already done that in maternity. If you have not, you need to. So gonorrhea, chlamydia, and HPV are the big ones. Know about those. Again, if it's a virus, I need an antiviral. If it's a bacteria, I'm going to need a bacterial antibiotic. Okay. Trichomonas, big time, only host is a human, and it's nearly always through sexual contact. So, think about burning, pruritus, painful urination, bleeding after sex. The urethra is also affected in the majority of females, and this can be seen as a green, frothy, foul smelling. So if you see those, you need to know kind of like why and what we would do. So males are usually going to have a clearer mucoid, purulent drainage. Antibiotics, avoid alcohol consumption. Think about this. Most STDs are going to be retransmitted, so you have to treat the partner. STIs are one of those things that are reportable because it affects other people. You cannot say, oh, I'm not going to tell anybody. I won't report this. This is reportable to the state. We need to track these things. Gonorrhea, again, that's why we do the erythromycin eye ointment in babies when they come out for gonorrhea and chlamydia. We want to prevent those infections. Severe eye infection is the biggest thing that we're trying to prevent. Gonorrhea is more of a yellow, white, or green urethral discharge, symptomatic of a UTI. So anytime you think UTI, you're also doing your STI screens as well. Chlamydia, again, that's why we're doing our antibiotic prevention of STIs, condom use, all that good stuff. Also remember your HIV positive patient. Syphilis, again, this is a problem because if you don't take your antibiotics, syphilis is called the great imitator because it's indistinguishable from other diseases. A sore, a canker sore is going to be a syphilis. Characteristic rash in secondary syphilis, rough red, brownish red dots on the palms of the hands and the feet. And then the latent stage, the hidden stage, is where those symptoms disappear, so they're not occurring, so people don't get it treated. All pregnant women need to be tested. Infants can be asymptomatic up to 2 years after birth. Central nervous system is the issue. Long bone abnormalities in the baby. So you can see a picture of syphilis on the baby. So you can see localized systemic infection, chronic diseases, chronic infections on the baby. So a lumbar puncture is needed to evaluate cerebrospinal fluid in the baby. Antibiotics, and then again, a penicillin allergy, you would need to provide a different antibiotic of choice. So know those STIs. And then when we talk about transgender, gender diverse care of children, again, now we increasingly recognize the spectrum of biological sex. LGBTQ, we know that they're more at risk for family discord, suicide, mental health issues. They need to have at least one supportive adult in their lives that would decrease the risk of suicide. And traditionally, an infant is assigned a sex at birth or even before birth with our 3D x rays, ultrasounds. So, primary sexual characteristics, this especially comes in play when we have an ambiguous baby. So, you know that at one point in time, you're all male and female, and then all of a sudden either it shoots up or it gets covered up, right? But the genetic material from the very beginning, okay? So, primary sex characteristics include the appearance of a penis, scrotum, or testicles, or ovary, vagina, and uterus. The secondary is at puberty, so breast development and facial hair. And then those identified as male at birth, it's because they have a growth in facial hair, voice deepening, and the limited growth of their genitalia. At female at birth, treatments limit or stops the breast development and delays or stops menstruation. So using growth hormones helps you to pause puberty. Gender dysmorphia is the feeling of discomfort or distress with the difference between the experienced or the expressed gender. Those are all in your book. Gender affirmation surgery, so performed with multi-specialty plastic surgeons. Again, there's male to female, female to male. Facial feminization, trans feminization, top surgery, bottom surgery, facial masculinity surgery, top and bottom surgeries. So again, the nursing interventions, asking what are your preferred pronouns or how you identify or define your gender more appropriate. Make sure that you know what their pronouns are. And then what are the words you describe your body parts. Are you in a relationship? Tell me about it, rather than are you married? Do you have a boyfriend, girlfriend? So asking questions a little differently. For new patient registration, ask for the legal name and chosen name, the partner information, and the sex assigned at birth, their gender identity, sexual orientation, and gender. Increasingly, medical record lists now preferred name and pronoun should be updated regularly. For inpatient care, they should have a policy on room placement and shared spaces for individuals to protect all rights of all patients. Private bathrooms, unisex bathrooms are often recommended. Okay, so then all we have left now is genetics. So chess question, what is menorrhagia? Menorrhagia, what is that? Menor tells me that it's about menses. Agia means blood flow, right? So I'm stuck between C and D. Is it too much blood? Oh yeah, absence means in. Okay, so now I know the answer. Amenorrhea would be no period. Fabulous. Okay, and then the genetic disorders. So I'm going to scroll through these really quick. Remember that human cells have 46 chromosomes, which means 23 from mom and 23 from dad. There are 22 pairs with males and females, and there's one pair of chromosome, one from each parent, which makes you XX or XY. The Y is 1/3 as large as the X and contains many fewer genes. So males have the Y chromosome, and that determines your maleness. We may have to get to that point of running genetic tests or no. Okay. So different types of cells reproduce by mitosis at different rates. Skin cells divide about every 10 hours, which means a cut really fast. Liver cells about once a year. So if you have cirrhosis, it's going to take a long time to repair that liver. Okay. Meiosis, the reproductive division that creates 4 daughter cells. It can take place in the germ cell, gametes, egg, and sperm. There are 2 divisions. Okay. So make sure you understand that. Oocyte is meiosis in the female. Spermatocyte is meiosis in the male. And then reproduction, if you have not seen like a National Geographic film, just look it up and search it and watch it, because it literally takes you through the entire reproductive cycle. Okay. Alterations in chromosome and development are where things go wrong in chromosomal development. So some of those in your book include trisomy 21. 21 is Down syndrome. You just need to remember your numbers. Down syndrome is that simian crease, protruding tongue, know the picture of a baby, know those features of a Down syndrome baby. Microcephaly, a small head, flattened broad head with flat posterior areas, a flattened middle of the face, almond-shaped upslanting eyes. Their ear does not match up to their eye. A small downward turned mouth, a small oral opening with a protruding tongue, low set ears, short hands that have a single crease, the simian crease. Okay, so all of this is in your book. Just make sure you understand the difference. So congenital heart defects are the biggest thing with Down syndrome. So we'll take them for a quick ultrasound of the heart, make sure we're okay. Okay, so other congenital anomalies along the just GI tract. Okay, know about these. Anal atresia, not having an anus, having it stenosed. Our esophageal atresia, tracheal esophageal atresia, Hirschsprung's disease. Know these. Okay. So Down syndrome's in there. And then we've got Edwards syndrome. Trisomy 18 is the second most common after Down syndrome. And this is overriding fingers, cranial features, prenatal growth deficiency, nail hypoplasia, short sternum. These are internal anomalies with severe heart defects. Many of these babies die before birth or within their first month. They have severe intellectual disabilities. Trisomy 13, Pauta syndrome, is least common and the most severe, and the usual survival is fewer than 3 days. So not compatible with life. So we provide support and end-of-life care. We provide for minimal intervention. Give them their time with their baby. The trisomy 18 and 13, we're looking for severe heart defects. We're talking about means of support, developmental milestones. Children who do live later in life, we're going to have methods of support for the family. Okay. Turner syndrome. Turner syndrome is an entire loss of X chromosome. So it's the only known disorder where a fetus can survive despite an entire chromosome missing. So Turner syndrome, abnormal sperm error, and a girl receives no sex chromosome from the sperm of the father. So the patient is a lone X from the mom. So we're completely lost our Y from our dad. So prematurity is common, feeding difficulties, severe gastroesophageal reflux, and failure to thrive. Often have webbed short necks, shield-like chest, streak-like ovaries, 1 and 2 diabetes mellitus, hypertension, autoimmune disorders, thyroid dysfunctions. So again, feeding difficulties, endocrine referral, genetic referral. And then cry to chat syndrome, if you look at that and you're like, cry of the cat, that would be good. Cat cry syndrome is deletion or possible portion of a chromosome 5 being gone. So they have a distinct high-pitched cat-like cry and their IUGR, intrauterine growth restriction. So profound microcephaly, you can see the pictures in the book. Lung dysplasia, heart. So severe CNS, developmental progress, high risk for depression, family support. You've got another one on Williams syndrome. Again, these are getting less and less common as we're going through these. So you need to know them, but the ones that were on the future slides, the ones previous, are more common to be on a test. Could they ask you it? Yes. They're less likely to be on the NCLEX or a test. So look at these in your book. Double check that you understand these chromosomal anomalies. The tooth disease on this slide, more common. Look that up as well. Duchenne's muscular dystrophy, absolutely. Spinal muscular atrophy, absolutely. Fragile X could be on there as well. Again, these are fully in your book, fully explained. Know the difference between fetal alcohol syndrome and your Down syndrome. Okay, so a thin phalanstrum, a thin upper lip is your fetal alcohol syndrome baby. So just know those, that Prader-Willi as well. In Edwards syndrome, each chromosome has how many copies of chromosome? What did we say? Was it chromosome 13 or 18? So 18. In trisomy 18, Edwards syndrome, they have 3 copies of chromosome 18. Okay, so that's a typical test question and what it would look like. So again, in this chapter, we talked about female anatomy, physiology, male-female anatomy, physiology, pediatric problems of the female track, pediatric problems of the male track, treatments for those, genetic disorders, transgender and gender diverse children, STIs, all that good stuff. All right, talk to you later.